Sir, you can start now.
We are live?
Yes, sir.
Good evening, doctors. My name is Ruchir Shah from German Remedies Zydus Healthcare. It is my great privilege today to welcome our esteemed speaker, Dr. M. Ganesh, and all the attending delegates for this GRACE program. GRACE means German Remedies Atelier for Clinical Excellence. GRACE has always been a gathering of scientific minds in the field of gastroenterology. Due to this pandemic, we are having this opportunity to conduct this GRACE program on a digital platform. And today we have a very esteemed speaker with us who will be discussing a very relevant and a very important topic of novel concepts in acid peptic disorders. So before I introduce the speaker for today, let me inaugurate today's event with the lamp lighting ceremony.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
So we are very privileged today to have amongst us Dr. M. Ganesh. Dr. M. Ganesh has completed his MBBS MD, MRCP CCST in gastroenterology from the United Kingdom. Dr. Ganesh sir has completed his PG diploma in gastroenterology from Salford University in London. Currently, he is the chairman and chief gastroenterologist at SG Gastrocare Coimbatore. To account for his achievements, Dr. Ganesh has been the first in the world to remove a small intestinal tumor by endoscopy by full thickness resection without surgery. He is the first in South India to dilate an intestinal stricture using only endoscopic technique in a 96-year-old man. SG Gastrocare was the first in South India to remove colon cancer for a 96-year-old man. And the first in South India to remove a large 3.5 centimeter bile duct stone purely by endoscopy technique without surgery. Dr. Ganesh sir has performed more than 50,000 endoscopic procedures. Dr. M. Ganesh has won many awards for his exemplary accomplishments in the field of gastroenterology. He has received the Gem of India Award at the All India Achievers Excellence Award Conference in Delhi. Dr. M. Ganesh has achieved the Lifetime Achievement Award in 2018 by Lions International Club. And Dr. M. Ganesh sir is the Star of Tamil Nadu Award in 2015. He has received the Sushrut Award for dedicated service in the field of medicine in 2015. Dr. M. Ganesh has also won the Best Researcher Award in Manchester in 2003. Sir, it is a great privilege to have you today with us. And with this, I would like to give the stage to Dr. M. Ganesh. Sir, please, sir.
So, good evening, everybody. And it's a great pleasure to be associated with the Zydus academic activity, which is relentlessly doing these academic activities despite COVID and lockdowns. And I'm glad that we all could see us in a digital platform and at our own place, at our own ease, and we can share the knowledge and can save time by this. In fact, the COVID pandemic has not separated us, but in fact, it has made us more closer and more frequently associated through webinars, even though we didn't have a physical contact. But through the webinar, the knowledge sharing is continuous. And I'm baffled to see so many academic activities streaming on the web, more than what we can do on a physical platform. So, and I once again thank Zydus for taking this initiative to share the knowledge of gastroenterology among the doctors. And I'm very happy to be associated with Zydus and all other doctors for joining us for this excellent academic program. I hope you will be enjoying this program because we are going to discuss about a very common topic. And in this common topic, we are going to touch upon the newer concepts and how to improve our practice and what the newer therapies and the new concepts is evolving in a very, very common problem, which is acid peptic disorder. I think before going into the slides, I just want to make sure that the audio and the video is clear.
Yes, sir. It is clear, sir. It is clear, sir.
Right.
Slides are still not shared, sir. Audio and video is very clear.
Right. I'm going to share the slides, but do we have the participants or they're hidden from the view?
Sorry, sir?
Do we have the participants at present or we need to wait for some more time?
No, sir. Participants are there which are viewing it directly. So here this will be the speakers.
Okay, fine. So I'll just start sharing my slides then. So hope the slides are open now.
Yes, sir. We can see the slides, sir.
Okay, you just give me some feedbacks if I ask any doubts from your side, from my side, because I just want to make sure that the digital platform is working in a harmonious way.
Absolutely, sir.
Sure. Thank you. So we are going to discuss about the acid peptic disorder. We know it is a disorder related to the acid and pepsin, which is a normal physiological compound or a chemical which is being in the body, but where it can become pathological and can cause disease. And we know that these are the most commonest disease all over the world, and it's a very common problem faced by every other individual in some point of time. So what are the new concepts? Before going into this, I think Ruchir gave me a nice introduction about me, but I finished my training from Manchester for gastroenterology and worked as a consultant in Sheffield University, and I was an interventional consultant for Sheffield University and Hallamshire Teaching Hospital in 2008. And then I came to India in 2013 and started my practice here. I was with KMCH as a gastroenterologist and the head of the department for gastroenterology. And then I started my own practice in 2013. This is our new setup, which harbors all the interventional endoscopic procedures and advanced gastroenterology clinics, including inflammatory bowel disease, pancreatic, and gastroenterological advanced interventional procedures, and pancreatic clinic as well. So that is our practice, which is in Coimbatore in Tamil Nadu, and we are placed in Navarampalayam, opposite to Ramakrishna Women's Arts College. Our aim was to bring in the world standard endoscopic and gastroenterology service to India at affordable cost to all of us. So whatever training I did in UK, I'm utilizing it for the benefit of our own community and society, and I'm very happy about doing the service to our own people. So this topic, I'm going to split into few sections. I'm not going to keep you for a very long time, but most of my slides are going to be like photographs, illustrations, new concepts, and case studies. So keeping you on the toes, I'm trying to keep you on the toes so that you enjoy the session throughout completely. So we have some interesting case studies and some definition of basic and advanced concepts to clear the view what we are dealing with. And as I told you, some illustrations and new concepts and newer treatment methods in acid peptic disorder. So I just begin with a small case study which we normally encounter in our general practice and specialty practice with middle-aged or younger age group or elderly population who comes with abdominal pain, and particularly this gentleman is coming up with an epigastric pain, and it increases with food and not much lead with proton pump inhibitor therapy for a few weeks time. So he was also losing appetite, and he never had melena, but a smoker. So no other significant past medical history, and the blood tests were all reasonably within normal limits. So it's a gentleman with an epigastric pain for 2 months, increasing with food. So there's a lot of things could be going on in your mind about gastritis, ulcers, stones, pancreatic disease, and all those things can produce the same similar type. But whenever they come with a pain which is non-settling with PPI, the first thing which we do is to do an endoscopy. So when we do did an endoscopy, this is what we found. You can see a large defect in the mucosa, which is in the D1 part. That is the first part of the duodenum. And you can see there is a damage and some acid hematine sticking onto the mucosa, and there is a breach in the mucosa. That is typical of a peptic ulcer. We call it as peptic ulcer because the acid and pepsin causes damage to the mucosa, and we presume the most common cause is due to this chemical producing injury and damage to the mucosa. So that is a typical of ulcer disease. And the ulcers can be due to many causes, which we will discuss one by one. So the diagnosis is peptic ulcer. So when we begin with, it is about
excuse me, sir. Little sound is lesser, sir. You can just adjust the sounds a little bit. It is coming very light.
Is it clear now?
No, still it is lower, sir.
I'll just adjust the sound and get back to you again. Sorry for the interruption. Okay, I hope the sound is much better now.
Yes, sir. Yes, sir. It is better now.
Yeah, I think I'm much far away from the mic, so that's how. So the acid peptic disorder comes under 3 classifications. It may be an ulcer, which may be in the stomach, duodenum, or even in the esophagus. So recall, whenever there is a damage to the mucosa by the acid and pepsin, then it comes under the acid peptic category. Sometimes we get small intestinal and large intestinal ulcers, which we cannot call as acid peptic because they are beyond the territory of acid peptic damage. So next one comes is the same symptoms, but they don't have an ulcer on endoscopy, so we call them as a second category, non-ulcer dyspepsia. And the third category, which comes under the classification of acid peptic disorder, is gastroesophageal reflux. This is because of the acid refluxing and causing the damage. So this is the 3 broad categories of disease comes under the classification of acid peptic disorder. So now we need to know the other term which has to be defined is dyspepsia. So we said non-ulcer dyspepsia, ulcer type dyspepsia. So what do we mean by dyspepsia? So dyspepsia is nothing but a Greek word which says a poor digestion or a bad digestion or a maldigestion. That means it's a constellation of lot of symptoms referred to the gastroduodenal region of the upper gastrointestinal. So not the lower gastrointestinal tract. Whenever the symptom complex is pertaining to upper gastrointestinal tract, especially what we call heartburn, pyrosis, acid regurgitation, sometimes difficulty in swallowing, atypical type of chest pain, retrograde pain, water brush or excess water secretion in the mouth, nausea and epigastric pain, bloating, belching, distension of the abdomen, all these things comes under the category of dyspepsia. So anything can be there which we can say it as a dyspepsia. So then how will you define gastroesophageal reflux, which is very common problem, everybody would have experienced it. It is normally the gastroesophageal flow should be downwards, antegrade. It's not a retrograde phenomena. When it's retrograde, it is a pathological. That means it has to travel in the direction it is supposed to travel, from the esophagus to the stomach to the intestine. But when the contents reverse their direction, the gastric contents entering into the esophagus and cause damage, then it's called a gastroesophageal reflux. And this causes damage to the mucosa, leading to injury, and we call them as gastroesophageal erosive disease, GERD we call. So this is an endoscopic appearance of OGD, where you can see the squamocolumnar junction, which is the esophagus, and at the beginning of the stomach, which is the columnar lining, rose coloring lining. So when there is a damage by the acid, so you can see here a lot of acid streaks entering from the stomach into the esophagus. So this is a retrograde reflux. So gastroesophageal erosive reflux disease. So the acid is going upwards than the normal direction, and it is causing damage. It's called grade 1, and first one is called grade 1. The second one is grade 2. We got two or three erosions seen because it looks like a linear jets of acid starts damaging the mucosa. So we call it as a linear erosive gastritis. Sometimes the erosions can be continuous, where repeated healing and injury leads to scarring of the esophageal lumen, leading to stricture, and we call grade 3 esophagitis. Or grade 3 reflux esophagitis. Or like after the stricture, it can goes into the grade 4. That means complete obstruction. So when there is no obstruction, we call them as grade 3, like a circumferential injury. When it goes into stricture, we call grade 4 esophagitis. That means severe form of acid peptic damage. The acid and the pepsin is refluxing into the esophagus from the stomach, causing the damage. Why are we worried about this? It's very important because when constant damage of the esophageal mucosa by the acid and pepsin can lead to Barrett's esophagus. That means a change in the lining of the squamous columnar layer from the squamous to columnar lining. So normally we need a squamous epithelium in the esophagus. Because of constant damage with acid, to withstand the acid and peptic related damage, the lining start changing into columnar, which is not a normal. It's a, like we can say, an ectopic lining of a normal area. So when there is an ectopic tissue, it always have a metaplasia, we call, and this metaplasia has the risk of becoming malignancy. This is what you can see in another endoscopy. It's a Barrett's esophagus, and then the squamocolumnar junction, the tumor is extending into the cardia from the OG junction. So these are the problems of a chronic reflux disease, and we are really worried because it is increasing in India. There is another term which we describe is called NERD. The first one I called it as GERD, gastroesophageal reflux disease. The second one now I'm telling you is non-erosive reflux disease. What do you mean by that? The patient has reflux symptoms similar to gastroesophageal reflux, like heartburns, chest pain, regurgitation. But when you see by endoscopy, there won't be any breaks or injuries, what I showed you earlier, in the endoscopic appearance by conventional endoscopy. That means by examining with a white light examination. When you shine a white light, we can see all the injuries superficial to the, which is macroscopic to the eyes. But sometimes microscopic injuries or changes at the molecular level or the beginning of the reflux disease cannot be visualized by white light examination or a macroscopic examination. Then how do you describe them? We do another technique. So when you use this blue-green variation of lights, you can see the changes in the esophageal mucosa. This is a normal mucosa where you can see the green is the blood vessels and the red one, small ones are the small capillaries arranged in a similar pattern which is normal to the in the tree buds. But when there is a significant acid-related damage to the mucosa in the beginning stages before GERD, you can see here there are dilatation of the and also pitting. These patterns is completely different from the normal mucosal pattern what you can see on a white light or a narrowband imaging. So when you see such changes, that means the patient is having reflux disease but not picked up by white light. So this is called non-erosive, and over a period of time they can either progress to gastroesophageal reflux or erosive esophagitis, or still persisting like this or without any changes. So this is called NERD, where we can detect these changes by NBI. This was a description of the microscopic description of the esophageal mucosa during the damage by the acid, which is visible by only by narrowband imaging, and the microscopic changes in the capillary level. So all these things I already discussed and described. Dilatation, tortuosity of the intrapapillary capillary loops, and increased vascularity at a squamocolumnar junction. Normally, squamocolumnar junction does not contain too much of vascular bed, but when you see darkness, red, which is dark red in color, and lot of tufts of blood vessels in the squamous columnar junction. This is a new phenomena which is happening, and due to the injury and reflex, it is responding to a reaction causing more vascularization. This is an early stage of reflux disease, which can be detected by narrowband imaging. The other description which we want to know is about peptic ulcer and erosion, because this also comes under acid peptic disorder, which we call like first one is the gastroesophageal reflux, which we described, and in that category we said erosive and non-erosive, and the second category is peptic ulcer. So what do you mean by ulcer, which is a basic terminology which we use from the medical college, from the first year itself, because it's a break in the mucosa. Whenever there is a break in the lining of the layers of the body completely, exposing the underneath surface, it's called an ulcer. It can be in the skin, it can be in the gut, or wherever it is. So in the mucosa containing gut, there is a complete breakup of the mucosa with loss of surface tissue due to continuous erosion by the acid and pepsin, and some damage by the bacteria or some toxic agents, leading to an ulcer. But if it is an incomplete break, or there is no complete erosion of the breakage of the mucosa, or only if there is a small inflammation and the lining is still intact, like this, what you can see here, we call it as a erosion. So this is how macroscopically it looks. I showed you the first case with an ulcer, typical ulcer punched out. You can see the mucosa is eroded and it is exposing the submucosa or the lamina propria of the mucosa. And here's a few erosions are there here and there, small ones, where you can see some injury, but there is no complete breach, some redness and inflammation, and that we call it as erosions. So we have described two types of acid peptic disease, and the third type I will discuss one by one, because we elaborated on the gastroesophageal reflux and the classification. Similarly, peptic ulcer also, we will elaborate a few things, because we know the commonest cause nowadays is H. pylori infection, because we never knew 30 years before H. pylori was the reason for the ulcer. 30-40 years ago, most of the people who ended up with ulcer with a major surgery, either a pyloroplasty or a vagotomy or diversion procedures, all these things were happening. But after this bacteria was invented, and we know that this is the commonest cause of peptic ulcer in the gastrointestinal tract, especially the duodenal or gastric ulcers. The second category would be the drugs, because we are using more number of antiplatelet, painkillers, steroids, and spinal organ type of drugs, and chemotherapeutic drugs also nowadays, leading to peptic ulcer, because the exponential expansion of cardiovascular disease, rheumatoid disease, and various connective tissue disorders leads to the expansive use of these medications leading to ulcer. So always keep in mind, H. pylori is a common, drug is the next, and sometimes stress will be the third most commonest cause of ulcers, which everybody will understand, because whenever you're
Yeah, we have just had a technical glitch. We'll just sort it out.
You can call him also. If you have any queries, you can post your queries on Q&A chat box. So after the session, definitely would like to address those queries. Good evening, doctors. Wait for a moment. We are trying to get the technical glitch solved on behalf of faculty. Right? He will join in a while. Meantime, you can put your questions onto Q&A chat box.
Sir is joined.
Okay, okay. You join, no? Okay. Yes, sir. You can share your screen. Ganesh sir.
Yes, sir. We can see you, sir.
Yeah, there's a small interruption with the Zoom.
The sound, sir. Sound.
Yeah, there was a small interruption. I think now we are able to see again.
No, sir. Sound is not there, sir. Sound is not there, sir.
Sir,
It is
sound
there.
is there. Sir, Ruchi,
So
sir,
we
sound
can
is
hear
there.
you. We can hear you. So
Yeah,
you can continue.
Yeah,
Maybe you can rejoin, sir, with the audio sound.
Yeah.
Sound is not coming, sir.
Ruchi, sir, everything is okay. Sir, you can share your screen.
Yeah.
Sir, sound is not coming, sir. Audio.
Are you able to hear now? Are you audible?
Audio is not coming, sir. Audio. You'll have to read.
So shall I rejoin again?
No, sir. You are.
No, sir. No, okay. Your voice is clearly audible, right?
You can
Okay.
start, sir.
You can start, sir.
Okay, fine. Thanks.
Yeah, please start, sir. Thank you, sir.
Okay. As I said, there are Humpty number of parietal cells which secrete the acid, but not all the cells secrete acid at the same time. As this diagram shows, some of the switches are on, some of the switches are off. So at particular point of time, only certain amount of parietal cells only secrete acid, not all the cells. That's a very, very important phenomena which we have to understand to address the pathology or the mechanism of the drugs. So we know that not all the parietal cells are on at a particular point of time, and only very few type of parietal cells are on, and some of them are switched off, and they interchange every frequently. And the other concept I want you to know actually is the pepsin, which we talked about the acid. The next is the pepsin, which is produced in the stomach, which is a protein digesting enzyme. And it also has a maximum efficacy in the pH of 1 to 2. So you can see this is the intensity of the action of the pepsin, where it is very high at between pH 2, pH 3. And after the pH, that means beyond 4, this is an alkaline type of pH. When it's approaching towards alkaline type of pH, the efficacy of the pepsin drops down. So it cannot cause damage to the mucosal protein. So this is a very important concept, because when you are using proton pump inhibitors, we need to reduce the acid production and also reduce the production of the acid and increase the pH beyond 4. Then you will have a maximum benefit. So that is how the pathophysiology and the mechanism of the drugs which we use works. And also go by the concept that we cannot switch off all the proton pump inhibitors at one point of time. Only few pumps we can switch off, and few pumps will always be active at one particular point of time, or they'll be sleeping at some point of time. And the third concept of acid producing damage is related to inadequate bicarbonate ions in the lining of the stomach. We have some bicarbonatic ions as well as mucus layering the inner wall of the stomach. But if there is inadequate bicarbonate, then it can also produce damage to the mucosa by the acid. So these are the three things which we are going to know, because these are the concepts which are used in developing the drugs in helping the healing of ulcer on acid peptic disorder. So this is one of the commonest reason of the peptic ulcer which I was describing, which is H. pylori bacteria, which is very common in all over the world. Actually, it is a common soul. That means it lives with us, and it is belongs to the flora of the gastrointestinal tract. But when it has become a pathogenic bacteria, that means because of mutation and excess unhealthy toxic foods which induces mutation in these bacteria, they proliferate and multiply to a larger number and become pathogenic and destroys the mucous barrier, because it produces urease enzyme that cleaves the urea into ammonia and hydrogen, and this keeps on helping to damage the lining of the stomach, which is the mucus. So when the mucosal lining gets damaged, there is a breach in the layer, so the acid easily enters into the cells of the stomach, which can start damaging the cells and produce ulcers and erosions. That's how H. pylori related infection produces peptic ulcer. So depending upon the severity of the ulcer, one of the European forests has classified it as from 1 to 3 types. So if it is 1, it's very severe, the mortality or rebleeding will be very high, because it's a bleeding spotting vessel. You can see the vessel is spotting from the base of the ulcer, because after erosion of the mucosa, the next layer will be submucosa, which contains a lot of blood vessels, but that can also be eroded by the acid and pepsin and produce significant bleeding and death. Suppose you see only a visible vessel, it's not eroded the vessel, but you can see the vessel. In the next stage, it will go into erosion and bleeding. Or sometimes we can see a large clot sitting on the ulcer. That is because it has bled and it is stopped by a clot. It is less sinister, and somewhat less sinister would be the forest type 2 and forest 3, where you can see a small hematinic dot, which is nothing but as an acid hematic sitting here, or a clear based ulcer, which is a very benign ulcer which can be treated very easily. But the first 3 type of ulcers will require an endoscopic therapy or some sort of endotherapy to prevent rebleeding and a complication. So that's how the forest has classified the ulcer into 5 types to make you understand which is most dangerous and which is less dangerous by endoscopic appearance. The more dangerous, the more importance we need to give, either by continuous proton pump inhibitor infusion or by an endotherapeutic mechanism. We need to stop the bleeding and reduce the morbidity and mortality. So as I told you, all the ulcers produced in the stomach or upper gastrointestinal tract are not peptic ulcers. They may be due to other causes also, not related to acid and pepsin. Then you can see here, I had a gentleman who after renal transplant came to me with dyspepsia, significant abdominal pain, epigastric pain, nausea and vomiting. Endoscopy showed various types of small erosions and ulcers in the antrum. It was very unusual, and then we took a biopsy, and you can see the biopsy shows owl-eye inclusions. You can see large inclusion bodies inside the cell, which is nothing but a cytomegalovirus, because whenever they're immunocompromised after transplant, they will put on immunocompromised drugs, suppressing drugs. This can lead to the opportunistic infection causing damage to the mucosa. Not necessarily virus, as I told you, bacterial tuberculosis. I have seen people with large ulcers, irregular ulcers, looking like malignancy, but on biopsy, it shows acid was bacilli, giant cells, granulomatous changes, suggestive of tuberculosis and caseating necrosis. So it's not common to have gastric ulcer due to tuberculosis, and sometimes in one of the individual we thought it's a peptic ulcer, treated him with PPIs and H. pylori eradication therapy because H. pylori was positive. This gentleman's ulcer never healed after 6 weeks also. We thought it's going to be a malignancy, so we took a biopsy, and the biopsy showed a lot of candidal fungal hyphae in the ulcer base and also on the surface of the ulcer. So when we knew that it was a candida producing the ulcer, and retrospectively this gentleman was also immunocompromised and he was using a lot of steroids. and the biopsy proved it is a candidal infection. He settled very well with fluconazole oral therapy as well as H. pylori and proton pump inhibitors. So other rare causes are nowadays is a very common cause or Crohn's disease also. I see a lot of inflammatory bowel disease patients. So whenever we scope by colonoscopy, upper endoscopy also shows some linear ulcers. And if you are in dilemma in the diagnosis of inflammatory bowel disease because of a non-specific ulceration or the biopsy is not clear, by endoscopy also if you see some ulcers and the biopsy shows some granulomatous changes, it is definitely inflammatory bowel disease, which is Crohn's disease. Sometimes hypoxia and ischemia can cause damage and infiltrative disorders. I had people with sarcoidosis and hematological malignancies infiltrating into the layers of stomach, producing ulcers and some foreign bodies. I can show you some examples where cancers also presenting like ulcers and the biopsy from the antral area, it gave carcinoma and sometimes lymphoma. The H. pylori infection can trigger lymphomatous changes, T-cell lymphomas, maltomas, and that can be treated with continuous H. pylori eradication for 4 weeks to 8 weeks and continuous suppression of acid for another 2 months with PPIs, which will help to relieve the ulcer and maltoma. Suppose if they recur, then we have to go for chemotherapy. But most of the H. pylori related lymphoma, which is the maltoma, mucosa associated lymphoma, we call, they respond to H. pylori eradication. This is one of the interesting case where the patient presented with abdominal pain. We thought it's a peptic ulcer disease, but this gentleman has swallowed his denture, he had a denture, which normally is not used nowadays. He was a 60-year-old gentleman, but this type of dentures, a single denture is used a few years back, maybe 10 years. Nowadays, we don't use them. It's very dangerous because they can easily fall into the mouth and into the gastrointestinal. This is occluding the pyloric orifice and damaging it and producing pain. He came after 3 days and we removed it completely. Sometimes the retained foreign body also can produce significant ulcer in the stomach, which is may not be a peptic ulcer, but a foreign body induced. As I told you, there may be infiltration with lymphocytes, sarcoid or amyloid or eosinophils. We have eosinophilic gastroenteritis presenting as ulcers. Only biopsy will reveal them. And lymphoma, I told you, and linitis plastica, which is a submucosal spread of carcinoma, and the surface can show some areas of ulceration and without ulceration also. So infiltrative disorders also can produce ulcers. So you have to keep in mind whenever you're seeing an ulcer in the stomach, not necessarily as a peptic disorder. The other disorders has to be kept in mind, and metastatic disease like melanomas can produce ulcers in the stomach. And we know that all these common drugs can produce ulcers, especially biphosphonates, alendronate. When you take orally, they are very, very corrosive and they can alkaline and they can damage esophageal mucosa, OG junction ulcers. And because the tablet size are very big, they mostly lodge in the OG junction and produce OG junction ulcer and gastric ulcers also. Methyl xanthines, continuous use of iron, and SSRIs, serotonin reuptake inhibitors, can produce ulcers. So not necessarily that ulcer can produce only one type of symptom. They can have an overlap. I said there are 3 types of acid peptic disorder, but each type will have a typical symptom. Like whenever if described as an ulcer, pain will be a predominant manifestation, and if it is a GRD, then the predominant presentation will be regurgitation and heartburn. And if it comes to non-ulcer dyspepsia, which we'll be classifying in the next, which means there is no ulcers, but they have symptoms similar to ulcers, especially like postprandial bloating, belching, satiety, nausea, pain unrelieved by foods and antacids. So this is called a non-ulcer dyspepsia because on endoscopy there are no ulcers, but symptoms more or less like peptic ulcer. So these are the 3 things which we normally describe in the symptom complex, but they can overlap also. All these symptoms can overlap with each other depending upon the pathology. I'll come to you with one another interesting case where I had an 88-year-old gentleman with recurrent anemia, mild abdominal pain, no other comorbidities. He's a very fit gentleman, referred for endoscopy to rule out ulcer. I was also under the impression that because of recurrent anemia, abdominal pain, it's going to be a ulcer or a malignancy in the GI tract. So when we did an endoscopy, we find multiple areas of erythema, which is nothing but gastrovascular, gastric antral vascular ectasia. The vessels are very prominent and they can start bleeding and can produce them. Using organ plasma coagulation, the probe, We have sealed all the blood vessels, and he recovered very well. And he lived for up to 94 years. And I don't think he never had any episode until he was alive for 6 years. So sometimes it can be misleading. Looks like an ulcer, but it could be a different pathology which can be treated easily by endoscopy therapy. I'll talk to you about another interesting case which I encountered. Very rare for people to see such cases. So 40-year-old gentleman presented with history of recurrent ulcers, melena, abdominal pain, recently developed dysphagia also, and he also underwent esophageal dilatation for dysphagia and stricture in the esophagus. He also had recurrent anemia and melena. Despite medical and endoscopic treatments with the dilatations and using endotherapies, he keep on having ulcers and not relieved by PPA therapy. So this is the endoscopic view of ulcer which he had developed in the mid-esophagus, and stricture and dilatation done following the dilatation. You can see such type of ulcers, large ulcers, prominent ulcers, and the gastrographic study showed multiple ulcers also, which he had outside done, and came with the report. You can see this is a small nodular area. On endoscopy, we found that in the duodenum, second part of the duodenum, close to the ampulla, you can see a nodular area. So immediately putting all these zigzags together, recurrent ulcer, non-healing ulcer, multiple ulcer with a nodule in the duodenum is nothing but the biopsy of the stomach, which was very much hypertrophic, also showed parietal cell overgrowth or parietal cell hyperplasia. On endoscopic ultrasound, you can see that we did an endoscopic ultrasound. The probe is here, top portion, and the mucosa is here. And there's a lumen of the stomach filled with water, but the lumen is very much occluded, and you can see the mucosal thickening. So plenty of thickening of the mucosa. So from here to here, it's approximately 2 to 3 centimeters. Normally the lining is 0.5 centimeter to 0.7 centimeter, but it's 3 times the normal limit of thickness of the wall of the mucosa of the stomach. That is typical of mucosal hypertrophy. Either it happens in linear plastica or parietal cell hypertrophy. In this case, biopsy showed parietal cell hyperplasia, where he didn't have a malignancy. So what was the cause for his parietal cell hyperplasia? The parietal cells are always stimulated by hormone gastrin to produce more acid. So there is excess production of gastrin in this gentleman, and the reason for his excess production of gastrin is Zollinger-Ellison syndrome, and he had a gastrinoma. That is the gastrinoma in the duodenum, which is the commonest site. You can see here, it's producing plenty of gastrin and leading to parietal cell hypertrophy, multiple ulcerations, thickness of the mucosa, and that is typical of Zollinger-Ellison syndrome. We normally read in MBBS, so which we can see clearly. So whenever the ulcers are not healing and there's multiple symptoms keep on coming, not responding to PPA therapy, keep in mind about Zollinger-Ellison syndrome or neuroendocrine dysfunctions also. Sometimes we get hypercalcemia, hyperparathyroidism, leading to significant recurrent ulcerations also. So the newer concepts nowadays we are coming with in terms of treating ulcer diseases. Does gut bacteria have a role in dyspepsia and ulcer? We know bacteria can produce gastrointestinal infections, but can they produce dyspepsia and ulcer? Bacteria are more in number. They outnumber the number of cells in the human body by 3 times. And that is the largest immune organ, and the bacteria is seen in higher concentration in the gut only. So they always have an interaction between the native immunity of the human body and the luminal bacterial commensal content. So you can see here that always we have an interaction between the luminal bacteria and the gut. The bacteria produces lipopolysaccharides and a lot of bacterial toxins which can enter through the junctions or the gaps between the intestinal cells. So they're normally guarded by tight junctions. When they become loose by continuous bombardment with the bacterial toxins, they become loose and lax, and then they allow the contents to pass through. So when they reach the lamina propria, there is a continuous stimulation of the T cells and the immune cells to produce interleukins and chemokinins, which can pass through the blood vessels and reach the liver and various parts of the body, and it can produce symptoms all over the body, and we call it as a leaky gut syndrome, where there is a change in the natural occurring bacterial organism by pathogenic bacteria, which can induce constant damage to the lining of the mucosa of the intestine and allowing the contents of the bacteria to enter into the circulation, which can lead to a leaky gut and a systemic manifestation of the various diseases, including peptic ulcer, gastroesophageal reflux, dyspepsia, depression, anxiety, and rheumatological manifestations and IBS-like manifestations. So it's very, very important that we need to understand that bacteria has a close relationship with us, and sometimes this close relationship can lead to a damage to the mucosa because of it's replaced by a pathogenic bacteria. So can we use this science to change it? So the bacteria, we can kill them by a bacteria, another bacteria. So normally human milk or curd or the human gut contains plenty of lactobacilli and enterobacteria. They fight against the pathogenic bacteria and replace them with a good effect. And when we use this lactobacillus or enterobacterium, they can be helpful in regenerating the damaged cells of the mucosa in terms of peptic ulcer or intestinal ulcers or intestinal damage. These bacteria can help to bring the cytoproliferative action, and sometimes Saccharomyces boulardii can kill the H. pylori bacteria also. So we give, whenever we know that H. pylori is the commonest cause of bacterial ulcer, H. pylori eradication can be combined with Saccharomyces boulardii, which can kill the H. pylori bacteria, and combining with lactobacillus can lead to regeneration of the cells and healing of the ulcer. So probiotics can have a big role.
Boulardii is also called as sugar fungus or brewer's yeast.
Okay. So that is Saccharomyces boulardii, which is a sugar fungus, which can be used in treating the or killing the H. pylori and helping treating the peptic ulcer. So bacterial content is very important, and knowing the content, we can use that bacteria also to treat the disease as a peptic ulcer, for treatment of peptic ulcer. So we know new technologies and concepts that the proton pumps does not function continuously. They function intermittently, switching off and switching on, newer concepts. And we know that there is a symbiotic relationship between the bacteria in the gut and the intestinal lining of the gastrointestinal tract. So whenever there is a leakage, there is a bacterial contents entering into the systemic circulation and worsening the bacteria. Peptic ulcer, and we can use the same mechanism by giving bacteria to help heal the ulcer and fight against the H. pylori bacteria. So we know all these new technologies and how to diagnose a peptic ulcer. Again, the most common way that we can diagnose peptic ulcer is whenever the symptom complex indicates that he may be suffering from an ulcer like pain, vomiting, nausea, postprandial pain. Endoscopy is the best way to detect ulcers or acid peptic disorders or significant gastroesophageal reflux, which needs some evaluation and grading. Especially, endoscopy has to be done when there is an alarming symptom like dysphagia, upper gastrointestinal bleeding, melena, loss of weight, loss of appetite, odonophagia, anemia, choking sensation, and also we do endoscopy in all people who are above 40 years when they present with such symptoms. And nowadays, we call it as a new onset of dyspepsia after 50 years requires endoscopy. But now we know that even before 50 years, people are developing malignancies and significant acid peptic disorders. So now the criteria has been redefined that anybody who's presenting with new onset dyspepsia above 40 years requires an endoscopy to assess and analyze the damage, injury, and grade and know the cause. So now we know that we are dealing with the acid peptic disorder by doing an endoscopy, or sometimes if you want to detect reflux diseases where the endoscopy and NB are normal, you can either use a manometric study, a 24-hour pH recording, which will give you a complete assessment of the acid exposure of the esophagus from the stomach. So how to treat acid peptic disorders, especially peptic ulcer reflux diseases? Most of them we use proton pump inhibitors as a medical therapy, but Is there anything else we need to know beyond PPA therapy? Yes. The first thing I would say is lifestyle changes, where we need to use a diet which is non-irritating and non-stimulating diet, which means well-cooked mashed food, less spicy, whole grains, barley, rice, and corn related food material. So whenever the patient has a peptic ulcer, we suggest such diet so that they feel soothing of the stomach and the ulcer heals fast. Curd, buttermilk, yogurt, lady's fingers, all these vegetables which contain a lot of mucus and mucoid type of material helps to heal the ulcer faster. And ulcer healing vitamins and minerals. These are again new concepts where vitamin C and selenium are antioxidants, zinc as immune capacity and cytoproliferative capacity, and vitamin A also an antioxidant and helps to increase the cell growth. So these vitamins and minerals help to heal the ulcer faster and helps the cytoproliferative mechanism. Everybody is talking about yoga after Prime Minister Modi ji has told us that in the Yoga Day, it's been past 5 years, it's been celebrated all over the world, and it's I'll say renaissance of our traditional mechanisms, which has been used in therapy also. So we have following yoga therapy in gastrointestinal disorders for an excellent cure. Some of the asanas we can see here is called Makarasanas, crocodile pose, and sometimes this is called locust pose, where you are exerting all your pressure on the stomach, and this is called Dhanurasana and then Vajrasana. These all poses helps to recirculate or redirect the blood flow towards the gastrointestinal tract, especially the stomach, which helps the healing of the ulcer and increase the cytoprotective nature, because they wash away all the toxins and accumulated damaged stuff by the increasing blood flow. So these mechanisms are scientifically proved, and it's been told to us by more than 10,000 years by Patanjali and various other gurus who've been experts in yoga without knowing what we do as an evidence-based practice. They demonstrated us these things are very much helpful in treating peptic ulcer. And one of the mechanism I would always suggest people in this COVID pandemic is also other pranayama, where it's called a kapalabhati, where you take a short inhalation and continuous explosive exhalations, which will clear the ENT area, the nasal sinuses, and also it increases the oxygen flow into the body, and especially typically to the stomach. And this is a great pranayama where it helps to tone the diaphragmatic muscles. We know that the diaphragmatic pinch is very much essential to prevent the acid reflux coming from the stomach into the esophagus. Apart from the normal sphincter, lower esophageal sphincter, we have the diaphragmatic pinch, the extra esophageal sphincter we call very important in reducing the content of the acid entering into the esophagus. By doing this Kapalabhati, now the science says in America they are trying it with electrical stimulation of the diaphragm or drugs to stimulate the diaphragm to increase its tone and reduce the reflux. We know that by doing this Kapalabhati, you can increase the tone of the diaphragm and increase the diaphragmatic pinch and reduce the acid reflux. And also it's helpful in healing the peptic ulcer. So it's very, very good postures which I would like to share with you as a scientific knowledge from our traditional Vedas. So once we know that lifestyle, food, and also medicines, then we know if there is a bleeding ulcer, which I told you earlier, they can be dealt with endoscopic therapy. So either by using an organ plasma coagulation heater probe, by connecting to the electrocoagulator machine, we generate electricity to cook the area. That means you heat it like boiling the egg. The most of the gastric mucosa is made up of protein. By giving an adequate amount of heat, the protein coagulates and forms a coagulum and stops the bleeding. And the blood vessels also get coagulated. That's how when you put a heater probe on a blood vessel or a bleeding area, the bleeding stops. Either you can use epinephrine injection also for temporarily to arrest the bleeding by increasing the vascular tone of the vessels so that its vasoconstricts and the bleeding reduces, and immediately you do a heater probe application and the vessel is coagulated. So by combining the technologies using heater probe and epinephrine, the achievement of hemostasis is very high, and sometimes we can use endoclips. I'll show you those images. Here you can see a combination of therapies we used by injecting epinephrine, applying a heater probe, and then if it doesn't settle, you can apply a clip. So you can see here, I had a patient recently referred from Ooty with constant epigastric pain and drop in hemoglobin, passing blood in the stools, and sometimes significant melena. Multiple endoscopies didn't pick up anything, but careful examination during my time, we are fortunate to see that there was a small ulcer base here which was continuously trickling and oozing. It happened when we were doing the endoscopy. He was fortunate and I was lucky to pick this up. And then we put a heater probe and coagulated that area. You can see here the area is completely like boiled or scorched so that there is no bleeding. In another case where we saw a small ulcer with a vessel, we used a clip to stop the bleeding from the bleeding ulcer. Sometimes we can use a hemospray, which is nothing but a mineral granules which stimulate the coagulated mechanism to produce healing of the ulcer as well as the bleeding. It's called hemospray. And the newer technology which we use to arrest the ulcer bleeding is using Avasco hemoclips, where you can see like jaw-like clips, which are bigger clips, and when you apply to the mucosa, it can take it up to the last layer of the gut. That means the serosa. So all the 4 layers can be included in the clip like a jaw. So it comes like a jaw and then holds the blood vessels and the mucosa, so the bleeding is completely stopped. A larger blood vessel can be dealt with Vasco clips, which we have done so many times. Smaller vessel by heater probes and normal hemostatic clips. I told you about the hemospray, which contains C325 granules, and when you spray the granules through the endoscopy onto the bleeding ulcer, it stops bleeding. And we are using more of NSAIDs and aspirins, steroids. There is a classification or there is a grading which shows that whenever the higher the age or higher the dose of NSAID we use or steroids we use, the incidence of bleeding risk from ulcer increases, and prior history of bleeding, there is a 13% chance or relative risk 13% you will be getting another bleed. So the aspirin, entry-coated or non-entry-coated, buffered aspirin, whatever aspirin, it has a risk of GA bleeding, producing ulcers, and we should be very careful. Supplementing with proton pump inhibitors is a must when we are using such drugs to prevent ulcers and bleeding. One of the dilemmas which we have is always whenever there is a patient who is on antiplatelet medication after cardiac illness, ischemic heart disease, been stented, coronary stenting, can we use PPI? And there was a myth between an interaction of clopidogrel and PPI therapy, because PPI therapy was showing that it reduces the efficacy of the clopidogrel. Is it true? It's partially true, because when we used omeprazole in the past, it interacts with the clopidogrel because clopidogrel is a prodrug. It's an inert drug when taken through mouth. It has to be converted into an active metabolite by cytochrome P system, which is CYP2C19, which is a major cytochrome enzyme which converts prodrug into an active drug. But omeprazole inhibits the cytochrome P450 system, especially CYP2C19. That means you are getting very much reduced antiplatelet activity because not much prodrugs are produced. So omeprazole has to be avoided when using with clopidogrel as a preventive drug. This is another cartoon showing various other proton pump inhibitors who has a role as a competitive inhibition on the conversion of clopidogrel from inactive to active stage. According to that, whichever proton pump inhibitor which has a major role in metabolizing CYP2C19 has a major impact on the conversion of clopidogrel to active clopidogrel. Well, as you see, rabeprazole has very less effect on the CYP2C19, and it's also metabolized non-enzymatically, which is very, very useful. So the interaction is very low, especially rabeprazole and other esomeprazole category also has an interaction with 2C19. Most of the rabeprazole and pantoprazole has a less interaction potential, and that rabeprazole has a very good track record of non-enzymatic way of metabolizing its content. So PPI clopidogrel integration, we avoid omeprazole, but we recommend rabeprazole as a co-prescribing drug to prevent ulcers, and it does not have an interaction with the clopidogrel. So this is a new science which we need to get clarified, where rabeprazole is a non-enzymatically metabolized, and it can be used along with antiplatelet medications without interfering with the action of the clopidogrel. So we use PPA therapy continuously in acid peptic disorders, including reflux as well as in the ulcers, but we don't get an adequate response. Why? Possible causes are because when we recommend PPA, people don't take it accordingly, and the compliance is not there, improper dosing timings, and it's a weak acid reflux, but predominantly a duodenal bile reflux, which can cause ulcers. And some people have significant visceral hypersensitivity. That hypersensitivity can produce significant pain not related to peptic ulcer. Psychological comorbidities and concomitant functional disturbances of the bowel can produce bloating, distension, stretching, and produce pain, which does not elicit PPA therapy. The most important thing nowadays we are seeing is a delayed gastric emptying due to diabetes mellitus and various drugs, narcotics and tramadol type of drugs which we use, which delays emptying, and the drug we take does not act properly also. So delayed gastric emptying is another cause for failure of PPA therapy, especially in diabetics and eosinophilic esophagitis. As I told you, whenever there is a reduction in the availability of PPI, bioavailability of PPI in the circulation, then the mechanism of PPI is lost. Either it is not absorbed properly or it is rapidly metabolized. In Indian context, we have a lot of people who have various combinations of pharmacogenetics. I'll tell you in the next slide what is that. And these are all the various causes which I can see on the slides. The PPA resistance, where they don't respond to PPA properly. Either the diagnosis is wrong, or taking it in a not proper way, or there's a delayed gastric emptying which you are not identified, or concomitant bowel disorders like functional disorders are there, which can lead to persistent symptoms. Or a different etiology like a eosinophilic esophagitis or a duodenal gastric reflux, which don't respond to PPA therapy. So by careful history, by endoscopic examination, and the way the tablets they are taking, we can come to a conclusion that whether the reason for PPA resistance. So why there is a variability in the actions of the PPA? Because as we know that the proton pump inhibitors are metabolized by cytochrome P450 system and mainly by CYP2C19. There is a genetic defect in this pathway where some people are having fast metabolizers. That means they metabolize the PPAs very faster, so the effect is very weak. Even if you take so many PPAs, they're easily or quickly disposed from the circulation, so there's not much enough PPA available to cause its action. So they are a biological variant where how much ever PPA give, they will quickly metabolize. Some are medium and some are slow metabolizers where they have a persistent effect. We are worried about the fast metabolizers where these fast metabolizers don't have a much good response to PPA therapy. So what is the alternative for these people when the PPA fails? We have another classifications of drugs which acts in a different pathway, not necessarily by blocking the proton pumps. We block through the prostaglandin pumps. So misoprostol is a prostaglandin E2 analog, which when stimulated, it inhibits the CAMP pathway in that the hydrogen pumping is stopped, because the CAMP is necessary for the pumping of hydrogen into the cells and into the lumen. So by blocking this hydrogen pumping into the cells by prostaglandin mediated mechanism, you can reduce the acid production. And the other agents, we know that sucral coat, bismuth are all coating agents which reduces the acid peptic related disorders. And if PPAs are not working, we can still try, because when there are fast metabolizers and genetic defect in using the PPA therapy, then we can still use H2 blockers, prokinetics, misoprostol, and sucralcate. And sometimes, not necessarily, all PPAs are resistant to treatment. As I said, rabiprazole is one drug where it is enzymatic, non-enzymatically metabolized, so they don't have an interaction with CYP2C19 cytochrome system very frequently like other PPAs. So we can use as an alternative to PPI. If they're not responding to pantoprazole or lansoprazole, you can use rabiprazole. Or if still doesn't work, then you can go for H2 blockers, bismuths, prokinetics, misoprostol, sucralcoat, and all those drugs. And then there's a newer variety which we need to discuss. A newer drug is there, which I'll tell you. And one more important concept which I want to talk to you about when I was discussing about acid peptic disorder is nocturnal acid breakthrough. So whenever in the night times, we can control the acid secretion during the daytime with the PPA therapy, but many patients come with complaints of rapid acid secretion during the night, volume reflux through the esophagus in the night, and that can produce quite significant amount of producing significant amount of acid-related damage to the esophagus during the night time. So you can see in this picture that there is a dip in the pH during this period of time, where you can see in the evenings and in the early mornings there is a significant reduction in the pH, and the pH parametry study shows that there is a nocturnal acid breakthrough where the pH is falling less than 4 and causing more significant problems. Why this happens? Because whenever you are lying down, you are losing so many mechanisms, because during standing, the gravity, saliva and esophageal clearance is very much good, but during the night time there is not much saliva produced, or not much of gravity helping you, because you're lying flat and the gravity is evenly distributed all over the esophagus. So in the night times there is no gravity help and no esophageal clearing by secretions. It's mainly through the esophageal motility. Only through esophageal motility the acid contents goes down and peristaltis is good, then there is less acid related damage. Poor sufferers of nocturnal acid breakthrough and severe problems are those with Barrett's esophagus. Whenever there is a esophageal dysmotility disorder or gastroparesis or gastric dysmotility disorders where the motility component is also lost, gravity is also lost, no secretion, then they get significant reflux during the night time and complicated gastroesophageal reflux. So as I told you, even during the night time, some of the pumps will be keep on working despite using PPA therapy in the morning, because we always have some pumps sleeping and some pumps active. By doubling the dose of rabiprazole, I think instead of single dose 20, going for a 40 milligram dose has been 20 milligram twice daily, has shown that we are trying to achieve more number of pumps to be blocked. And nocturnal acid breakthrough can be relieved by using this type of therapy, is a long-acting drug in the night or a prokinetic drug added in the night, which helps the esophageal motility. So rabiprazole has shown very good effect in reducing the nocturnal acid breakthrough. And I told you all these things because it is not influenced by cytochrome system and it's predominantly metabolized by non-enzymatic system. So we use common drugs along with PPA therapy, which have an interaction with the PPA therapy. And when you see here, rabiprazole has no much interactions with other medications metabolism. Otherwise, when we are using some omeprazole, they decrease the metabolism of diazepam so that you get more sedative effect and also less phenytoin related effect, because omeprazole stimulates the cytochrome system some point of time where they reduces the metabolism of phenytoin, or the dose of phenytoin. Even if you give lesser dose, they get more actions. So decreased metabolism of phenytoin and warfarin happens because the omeprazole inhibits the cytochrome system and enhances the toxicity of phenytoin and warfarin. But there is none effect with the rabiprazole. So rabiprazole is a very good drug in terms of using when you are administering with another drugs, or during nocturnal acid breakthrough, or when you are combining with the antiplatelet medication where it does not have an interaction with the clopidogrel system. Another concept which I want to touch upon is obesity, because obesity is increasing in India. And do you think that obesity increases GRD? Typically, yes. Because when you can see here, whenever the body mass indexes keep on increasing, there is a multivariate increase in the risk of gastroesophageal reflux, because there is a relationship between the body mass index and the transient lower esophageal reflux relaxation, the sphincter relaxation. Because during the heavy weights, when there is an excess pressure on the stomach by the fatty content, leading to excess reflux, and also these fatty substances has a chemokinin effect, and it has a relaxing effect on the lower esophageal sphincter, stimulating the reflux mechanism. Again, as I told you, Kapalabhati is one more mechanism where you can tighten the diaphragmatic pinch. Suppose people have hiatus hernia, they don't have a good diaphragmatic pinch, which can lead to significant acid reflux. By doing Kapalabhati, you can increase the diaphragmatic pinch and reduce the acid-related reflux. So we have discussed so many type of drugs like PPA therapy, which if it fails, we can use H2 therapy, either which of the PPA therapy like pantoprazole or rabiprazole or omeprazole. We found that rabiprazole is much better. And do you have any other drug apart from these drugs? Yes, the newer kit on the market, which is more powerful than proton pump inhibitors or potassium competitive acid blockers. We call them PCAP because they block the potassium channels. Instead of hydrogen potassium pump, where the proton pump completely blocks at the base of the hydrogen potassium ATPase, they selectively block the potassium channels, potassium competitive blockers, where it can work throughout day and night. It does not need an active pump. So because the proton pump inhibitors are always given an empty stomach, or when you're about to eat where your appetite is high, there is higher secretion of acid and more number of pumps are opening to produce more acid. The proton pump inhibitors work much better, blocking the active pumps, but they don't act on the inactive pumps. But this potassium competitive acid blockers, this is a new drug which is called vonoprazan, can block the potassium pumps even when they're at rest or when they're active. So it's one of the mechanisms where it's used in nocturnal acid breakthrough, where you can continuously block the pumps and get a very good relief from the peptic related disorder. And is useful in H. pylori therapy, eradication therapy, because of constant suppression of acid production leads to complete elimination of H. pylori bacteria. And there is a comparison between these PPIs and PCAP. I think we are running out of time. I'm just going to try to go fast, as I told you all things about PCAPs. So the next question asked is, long-term use of PPI is safe? Yes, we always say it is safe because even though it has produced adverse effects related to acid inhibition and adverse effects related to non-acid inhibition, because as a drug, as such, any drug can produce adverse effects on the body parts, including interstitial nephritis, collagenous colitis, dementia, cerebrovascular ischemias. Because of acid suppression, there is less absorption of iron, B12, and sometimes they say vitamin D deficiency, also hypermagnesiemia and anemia can lead to gastric carcinoids, infections, because acid is a natural immune protector, and if you suppress the acid, small intestinal bacterial overgrowth, as well as you are losing the innate immunity in the stomach, leading to opportunistic infections. But they're not much proved as such, because you can see here many studies where they have used PPS for a longer period of time. There's no increased risk of malignancies or malabsorptions. But I have seen people with anemia, B12 malabsorption, and pernicious anemia in these individuals due to continuous use of PPI therapy. But nowadays we are using more PPI therapy because we are using it for heart diseases, rheumatoid arthritis, where there is a painkiller has been constantly used on your PPI, and predominantly we use it for ischemic heart disease when the people are using proton pump inhibitors along with antiplatelet medications and double dose platelet medications. Sometimes even despite giving, as I told you, PPI therapy, they don't work in acid-related reflexes. As we thought about, all the ulcers are not peptic ulcers. All GERD is not truly GERD. So I had a 32-year-old man who had heartburns, not responding to PPI therapy. Endoscopy showed rippling of the esophagus, but not much damage. Biopsy showed, you can see here, a lot of eosinophils infiltrated into the mucosa. This is typical of eosinophilic esophagitis, which can produce typical of esophageal gastroesophageal reflux, but only biopsy can differentiate whether it's an NERD or a GERD or a completely unknown entity, because this requires treatment with inhaled budesonide, which completely helps to clear the infiltration of the eosinophils and symptoms. Again, another chap with dysphagia, odonophagia, significant pyrosis, Kobe shows curd-like precipitates on the esophageal mucosa. You can see round precipitates. They're nothing but esophageal candidiasis, which is fungal infection, which can present similar to reflux-related disorder. Sometimes dysphagia may be due to an upper esophageal ring or a lower esophageal ring on endoscopy. Skarsky ring we call produce dysphagia, and sometimes foreign bodies, which we can see. An elderly lady is a 91-year-old lady, which we scoped and found that she had a large piece of mutton sticking to the throat, came 3 days after taking the meat, saying that she could not swallow and severe pain in the chest and burning. Initially, we thought a malignancy, but it's a short history and the food intake, she gave the history, then we did the endoscopy, took it out within few minutes by endoscopy technique. So I'm not going to touch about very much about other part of the third part, which is non-ulcer dyspepsia, which I'll finish in exactly 2 minutes. So because the classification does not end by completing non-ulcer dyspepsia, because acid peptic disorder, as I said, one is because of ulcers, number two because of reflux, GERD, and the third is non-ulcer dyspepsia, where there's no ulcer but people have dyspepsia. This is what the definition is. And the most commonest reason is either esophageal dysmotility disorder, achalasia cardia, nutcracker esophagus, or diabetes mellitus, or systemic sclerosis or connective tissue disorders leading to reduced esophageal peristalsis and dyspepsia. Or it's a functional dyspepsia, or sometimes people do take a lot of antipsychotic medications which can cause gastroparesis or gastric stasis or esophageal dysmotility. And related to dyspepsia, which is persistent nausea, vomiting, fullness, bloating, pain, all these things. And we need to exclude diabetes in all these individuals because diabetes is now becoming the most commonest cause of non-ulcer dyspepsia. I told you all these things can produce dyspepsia. We have to think about, apart from the peptic disease, electrolyte imbalances, endocrine disorders, cardiac failure, all these things can produce dyspepsia and sometimes congestion of the stomach and intestinal tract leading to dyspeptic symptoms. What do you do for them? Do they respond to PPA therapy? PPA therapy alone cannot have a benefit in these individuals. We need to use some drugs which can stimulate the motility of the gastrointestinal tract, either etopride, clopride, proclopride, or acoshamide. Acoshamide is nothing but an acetylcholine esterase inhibitor or M1, M2 muscarinic receptor inhibitor, so that it enhances the activity of the acetylcholine. Similarly, etopride also inhibits acetylcholine and inhibits D2 receptors, so that they produce more acetylcholine at the neuroterminals. And acetylcholine is nothing but acetyl neurotransmitter, which increases the muscular contraction of the smooth muscles. Proclopride acts by 5-HT4 receptor mechanism, 5-HT4 receptor agonist, and it's a very good drug in the lower GI tract stimulation of intestinal motility, because 5-HT4 receptors are situated more in the colon and the distal ileum. So whenever the dyspepsia is due to the lower GI tract, then you can give proclopride. And when there is a problem with upper GI discomfort, bloating, belching, especially in diabetics, and when you suspect gastroparesis, etopride or acoshamide can be a better value in treating them. So thank you very much. Even though we exceeded 5-10 minutes because of the technical errors, I apologize for that. But I hope that I have shared as much as possible content related to acid peptic disorder, because it's a vast ocean. I'm trying to get it everything in a nutshell, and we discussed various aspects of acid peptic disorders in terms of treating ulcers, reflux, new concepts in ulcer mechanism, new drugs in treating peptic ulcer disease and gastroesophageal reflux, including nocturnal acid breakthrough.
Yes, sir.
Yeah, are you able to hear?
Yes, sir. Yes, sir. We can hear you, sir. Please continue.
Okay, I hope there was not much interruption. There was a sudden drop in the data, so we couldn't continue.
Yeah. Please continue, sir. We just lost you for just 1 second, sir.
Fine, thank you. I was briefing that it's a summary.
Your video is not coming.
There's a lot of new concepts which we went through very fast, and I hope those information.
Maybe his network issue.
In terms when I've seen patients
Yes, sir.
with related disorder. So I again thank Zydus for organizing such a wonderful webinar session where we can share our interesting thoughts with all of you. And I thank all the audience and doctors who participate in the webinar on a Saturday evening and enjoy the session. Thank you very much.
Thank you so much, sir. Thank you so much for that excellent presentation, sir. And I would like to thank you from the bottom of my heart, sir, that you could spare time out from your busy schedule. And sir, actually, if you would permit, sir, we have certain questions. The session was so interesting that there has been a lot of feedback and some doubts also, sir. If you would permit, I would just read up the questions, some one or two, if you would say yes, sir. Yeah, Dr. Ganesh. Hello. Sir, can you hear me, sir?
1 minute. Yeah.
Yeah, can you hear me, sir?
Yeah, I can hear you. Can you hear me?
Yes, sir. Yes, sir. I can hear you, sir. And the video is also clear, sir.
Okay.
Yes, sir. I wanted to thank you, sir, for that excellent presentation, sir. And the interest level was so good, sir. We had around 1,000 live logins, sir. So
Oh.
so that was excellent talk presented by you, sir. And sir, if you permit, we have some questions, sir. If you would like to take it, sir.
I can take it. I think a few questions, please, because I'm running out of time.
Yes, sir. We'll just take two questions, sir. Two questions, sir.
Yeah, fine.
Yes, sir. So one is from Dr. Mahesh Chandra Junjunwala from Calcutta. How would you diagnose non-erosive GRD if you do not have NBI facility?
Yeah, okay. We can do two things. Either by 24-hour pH monitoring to see whether it's a real acid reflux producing the problem. If the acid reflux is not much seen by the 24-hour pH manometry, by doing an esophageal biopsy, we can exclude other causes, like as I told you about eosinophilic esophagitis and also esophageal dysmotility disorders, where we can diagnose them by using a manometric study. The non-ulcer dyspepsia may be due to a dysmotility disorder or an infiltrative disorder into the esophagus. Biopsy will tell us. Sometimes even NPA is normal. Biopsy can show you basal cell hyperplasia or basophils infiltrations or inflammatory cells increasing in number in the basal layer, suggestive of reflux-related phenomena.
Great. Thank you so much, sir. Sir, we can take one more question. Dr. Prashant from Gadag is asking, sir, any new regimen for the H. pylori treatment, sir?
New regimen, we still are using amoxicillin, clarithromycin, and that is the best combination we are using at present. Along with we use Saccharomyces boulardii and bismuth, which can increase the efficacy of the H. pylori eradication. And the second line we use levofloxacin tetracycline combination along with esomeprazole or rabeprazole 40 milligram twice a day, along with Saccharomyces boulardii and bismuth. Sometimes I use zinc carnosine in combination in resistant cases to eradicate H. pylori therapy, and we prolong the therapy if it is not responding to the first time with single therapy. From 1 week therapy, we can go up to 3 weeks therapy.
Right. Thank you so much, sir. Thank you so much. Sir, we have many questions. Maybe, sir, on a later date, we'll just share the questions with you and then answer all the questions to the delegates, sir. We have our business head with us, sir, Mr. Narendra Devde. So I would like to request Narendra Devde, sir, to please deliver the vote of thanks. Sir.
Yeah. Thank you, Ruchir, and good evening, Dr. Ganesh, and one and all. I was just going through and listening to the whole session, and the session was really informative, and you tried to keep it as simple as possible, which I was going through each and every slides of yours, Dr. Ganesh. I think wonderful job done, and I really thank uh, on behalf of my entire team of German Remedies Pharma that you could spend your valuable time during this situation, and you really took time out of your schedule and made such a beautiful presentation for the entire audience. I'm sure the audience must have liked, and it was so evident that we had many questions, but we had to curtail down because of the paucity of time. So, which talks about the kind of interest which has been generated through your talk, and really it is heartening to see such kind of talks which is happening. And I'm sure I'm very happy that my entire marketing team has really put in their efforts to organize this talk under the heading of GRACE, which we call as German Remedies Atelier for Clinical Excellence. I think that is what is a precise objective. We've been talking about advances in the medical field every now and then. I think given to understand that medical field is always very dynamic, and it is always evolving with newer and newer things. However, when it comes to many advances in the academics, more importantly, what matters to the clinician in our country is basically the clinical expertise when we share with them, because they relate that in their clinical practice. Because whatever talk we do, when they see something is useful for them to implement in their practice, I think that values the most. Whether it is documented somewhere or it is not documented somewhere, perhaps it doesn't matter to that extent, but it does matter that it is used by Dr. Ganesh, and that is what makes it different. And in today's session, I think that was very evident, which I could see. So my heartfelt thanks once again to Dr. Ganesh for a wonderful talk. My thanks to the entire audience, all the doctors, those who have really taken time out of their schedule on a busy one Sunday and could spend time listening to this talk. My heartfelt thanks to the entire marketing team and sales team, those who could gather so many people for this session. And I'm very proud of my team who has really put in such a hard work to really make this webinar a successful one. I'm sure it was. Uh, Currently, we all know that we are passing through a very difficult time. When we started these seminars last year, in month of March, April, we were also in the similar situation today, but perhaps with the more scare and more sensitivity, because we are seeing a lot of people are getting positive with the corona, and many of our near and dear ones, we are losing them. So we are passing through a very, very difficult time, and in such kind of time, remaining connected with each other is very important at this point of time. This virtual platform helps us to get that particular opportunity, and that is what has been the initiative from our side, that we remain at least connected to people with this, and at the same time we share informative information, as well as we share our clinical expertise. I sincerely, from my side and on behalf of my team, I sincerely pray to God that we should be out of this situation sooner. I don't know when that going to happen, and we are really looking forward to meet all of you in person, in physically, because that's what we enjoy. And currently, we don't enjoy this virtual world, but we are into this. We are compelled to get into this kind of situation. So let's hope and pray to God that we are out of this situation very soon, and we would like to see Dr. Ganesh face to face, and all doctors, those who have attended today's session, of face to face. And that is what is my wish on behalf of. Once again, thank you so much. And let's hope the God bless each one of us, and we are out of this situation as soon as possible. So thank you so much, and a pleasure to have you with us as an esteemed faculty today. And thank you very much, all the doctors, those who have attended today's session. Thank you so much.
Thank you all. Thank you very much. Stay safe and be safe.
Yeah.
Bye.
Thank you, sir.
Thank you, sir.
Bye, sir. Thank you, sir. Bye, bye,
Thank
bye,
you.
thank you,
Bye.
thank you.
Yes, Jignesh.